This episode is sponsored by Dr. Chrono by EverHealth, the #1 mobile all-in-one EHR. Built specifically for medical practices, Dr. Chrono includes an integrated feature that powers a seamless payments acceptance experience. Dr. Chrono Payments offers multiple ways for patients to pay as well as insurance credit card processing. As a Dr. Chrono customer, you can easily activate our fully integrated payment solution that will streamline your cash flow and help you get paid anytime from anywhere. Deliver the best patient experience with a fast and easy way to collect payments. Visit drchrono.com/payments. That's drchrono.com/payments to learn more about Dr. Chrono today. Direct primary care is an innovative, alternative path to insurance-driven healthcare. Typically, a patient pays their doctor a low monthly membership and, in return, builds a lasting relationship with their doctor and has their doctor available at their fingertips. Welcome to the My DPC Story podcast, where each week you will hear the ever-so-relatable stories shared by physicians who have chosen to practice medicine in their individual communities through the direct primary care model. I'm your host, Marielle Concepcion, family physician, DPC owner, and former fee-for-service doctor. I hope you enjoy today's episode and come away feeling inspired about the future of patient care, direct primary care.
Hi, my name is Emilie Scott, and we are with Halcyon Health DPC. And to me, DPC is a safe space to be a true doctor.
Hi, my name is Dr. James Gaor, and to me, direct primary care is about being bold to find balance.
And this is our DPC story.
Dr. Emilie Scott believes that the best healthcare comes from a meaningful partnership between her and her patients. She has found that direct primary care is a great way to facilitate this. She is originally from Orange County, California, and she trained at the Mount Sinai Beth Israel Residency in Urban Family Medicine in New York, New York. She completed a fellowship in Integrative Medicine with Dr. Andrew Weil as well. She loves to teach and is an assistant professor at UC Irvine, having won the Teaching Award in 2010. She enjoys spending time with her awesome husband and being a kid with their 2 kiddos. Dr. James Gaor was born and raised in California, but ventured out to the East Coast to become board certified in emergency medicine after training at Albert Einstein College of Medicine in the Bronx, New York. He is a self-described technology geek and enjoys the thrill of finding simplicity within chaos. He feels that direct primary care is leading healthcare into the 21st century. In his spare time, which he always wishes he had more of, he likes to trail run, cook and eat real food, and spend time with his wife and 2 kiddos as well. They opened Halcyon Health DPC in 2016. Welcome to the podcast, Dr. Scott and Dr. Gaor.
Hi.
Thank you
Thanks for having us.
I will totally admit this. I'm totally fangirling out. These are my heroes, people. These are, when I learned about DPC back in 2019, it was Dr. Janine Rodums who opened in the same year as you guys up in Santa Cruz. She said, "Oh, you're thinking of doing this with your husband? You got to contact Emilie Scott. You got to contact James Gaor." And I was like, great. I don't know how to contact them, but oh my gosh, when I saw you guys in person at Hen Summit, it was just like, whoa, they're right there in person. And so this is such a treat to, be able to talk with you guys, with a little bit of DPC under my belt also now, but to hear your guys' story at this time in my life where my husband is actively joining Big Trees MD. So, and also I'm super excited for everyone who has not heard your story to hear it on the podcast. So I want to go back to how you guys both grew up in California and then ended up in New York for training. So how did that all happen?
Can we start by just saying when we first met you?
Yes.
When we first met Marielle, we were blown away. She was at the Hint Summit with a notebook, and she had so much energy. And so I'm also a fangirl. Just wanted to start there.
And she has more energy now. So I don't know. We'll talk later about what you're drinking. But yeah, there's a lot of energy.
Yeah. So we're grateful for what you've been doing for the DPC movement. So thank you.
Yes.
That's awesome.
So how do we get started?
Yes. How did you guys get started? Because California transplanted to New York. Like Dr. Nitin Gupta was similar. Like I was transplanted to Nebraska. I couldn't couldn't for some reason make it all the way to the East Coast. But how did you guys end up in the East Coast?
Well, that was a matter of medical school where we got in together because we wanted to be in the same place because we were dating at the time. So, and we wanted to see something different.
Yeah, we started dating in college. So we started off as friends and both decided we wanted to go to med school together. And so that was kind of where we ended up. I actually wanted to go to New York. I was getting a little bored of California. I got a little antsy. And so New York was one of the places where we both were accepted.
That's awesome. And when you guys were practicing in New York, because very often, and this is more so from residents that I hear this from, but people who have practiced in New York, again, from what I've heard, is they get a lot of exposure to like full scope practicing, physicians practicing at the top of their game because there's so much need. So when you guys look at your exposure and your training in family medicine and emergency medicine, what did you aspire to do and be as a family doctor and ER doctor, given that you were exposed to training in New York?
Well, so when I trained, I was able to access an integrative medicine fellowship. I think that really helped form my sense that I wanted to look at the big picture. To me, integrative medicine was more of just being a really good primary care doctor, kind of learning about nutrition and all of these different things. I think seeing, to your question, seeing a breadth of things in New York, I think also just exposed the healthcare system for its failings. So that was a pretty powerful experience, just seeing people fall through the cracks and where we had to pick up as trainees and all of that. So.
Yeah, I think I was a little more naive to how, broken the system is and was at the time. I think, going back to, we were, this is 25 years ago, thinking about, where we wanted to go to medical school and train. I was still this, old teenager, young adult, wanting to do emergency medicine, and it's cool, right? Like, you do all the fun things, the trauma, and you get like the wide breadth of clinical experience. You could be the cowboy. So New York was definitely an amazing place to do that and have, that experience of just learning all of these different skill sets. And along the way, clearly, as you can tell for where we are now, all of the things, all of the failings of our healthcare system, they filter down to the emergency room from my experience, and it impacts, the society as a whole. So it's, incredibly humbling to have practiced there. And I'm still drawn to those, those communities, to serve those communities. And I think, DPC specifically can address that moving forward.
I love it. I just literally came home from seeing a 2-month-old in the office because their parent was worried about them, and totally a reassurance visit. But it was like, you didn't have to go down 30 minutes to the urgent care, wait the 5 hours in the urgent care, or better yet, on a Saturday, go to the ER because the urgent care is not even an open option. So I love that we're all doing what we're doing. We're all part of this movement to really impact everyday Americans and not, try to narrow down the gaps where people would fall through healthcare in places like New York. So let me ask, how did you guys make it back to California? And what were you looking for in terms of jobs in California? Were you looking to be employed when you moved back, or were you looking to be independently practicing?
So for me, it's straightforward, like, going to, and, we could speak about this in length too. I mean, our training traditionally is in the medical field, right? You go to college, you go to medical school, you go to residency, you get a job. I mean, it's very linear, right? I mean, if you really think about it, it's incredibly simple. The cookie crumbs are there. They're really delicious cookie crumbs because, you're going to get paid well at the end of the tunnel. So for me, it was a simple, like, okay, I'm an ER doc. I'm going to work for a hospital, and I'm going to do my thing. Interestingly, near the end of residency, I knew this. I already started feeling, okay, well, this has a particular lifespan in terms of my career. Like, I just couldn't see myself sewing up a drunk person's lip laceration on a Friday at 5 a.m. forever, right? As fun as it was. So there was already some like rumblings in my inner soul of like, there's probably going to be something more down the road. I didn't know what, but I mean, for me, it was a very traditional look for a hospital-based ER position.
Yeah, similarly, we were looking for location. Our family is in Orange County. So we moved back here to be with them and have our kids. And we have primary care jobs. So we thought we could go anywhere. So, and then it was just looking for the best fit of a job when we got here. So I ended up at academics at UCI and an FQHC, which fit well with my desire to teach and work with the underserved. And so that's where we started.
Yeah. And I actually ended up with a rare find, a small Democratic owned ER group in Long Beach, which, unfortunately is getting bought out by private equity, but that's a whole nother conversation. But yeah, I mean, all of these independent groups are no longer existing.
It is sad. And Emilie, you hit it on the head. It's like we assumed when we graduated medical school and residency that we'll always be employed. We're physicians. And unfortunately, that's not the case. And I don't know if medical students and residents are being told that, but I think it's very important to mention that on the podcast because there have been so many people in this movement, my husband, included, in that the need for physician-led care is not the demand when people are looking for how do you see patients, right? So when it comes to, Emilie, you're talking about this FQHC and also a position with UCI and being able to teach as well as work in a community that was by your family as well as in an underserved community. When you say underserved community, what was that demographic like? And James, were you seeing a community that was similar? Stay with us. We'll be right back. Thank you to Spruce Health for supporting the My DPC Story podcast. The ways we communicate have changed dramatically over the past decades, but technology and tools in healthcare have not kept pace. Patients want more access and digital convenience, as well as the ability to text their care teams. Care teams are inundated with more communication and rising expectations, but are still using tools and technology stuck in prior decades. Spruce Health created a solution for the tech-forward DPC practice by creating a communication product designed to serve both the patient and the doctor through intuitive HIPAA-compliant workflows, tagging, scheduled messages, and triage templates ready for use, whether you're on your phone or in the exam room. New users get 20% off for the first 12 months of a paid plan with code MARYAL20. That's MARYAL20. So check out Spruce Health today at sprucehealth.com or check out the link in the show notes.
Yeah, I mean, it's a federally qualified health center. So the patients that go there are patients who cannot afford meaningful insurance, so people in need. So that was really the demographic, a pretty diverse group of people. When I got there, actually, seemed to be a lot of drug-seeking patients, so that was quite a challenge. And then a lot of very complex patients that, communication could be a problem, people from lots of different backgrounds. So it was a wonderfully challenging job that I was not given the proper resources to pursue.
Yeah, similar with me. I mean, I was in downtown Long Beach. So I had two hospitals, same group. But yeah, downtown Long Beach, underserved, a lot of uninsured, underinsured patients there, trauma, very inner city, urban population, which I really enjoyed, was very challenging in different ways. And then another local community hospital, a little more diverse, working class population. So just such a great learning opportunity to just meet so many different people. That's why I love being a physician, right? I mean, connecting with so many different people. It's been a great experience.
And when you, Emilie, specifically, you mentioned resources and you weren't able to be in a place where you had the resources that you needed to continue on there. What were some of those resources that you were probably asking for and not getting, even though you were asking for them?
I mean, that's easy, right? I'm a fresh graduate from family medicine residency. I have patients with, 15 things on their problem list and 20 different medications. And I have a paper chart and I have 10 minutes and I don't speak their language. And so we could go on and on about what you need. You need more time. You need someone to help you translate. You need a mentor there to help you because you're a brand new grad, or you need more than enough time so you can read and learn. I don't think 90 minutes per patient would have been enough time to really do an accurate job coordinating care there. And then beyond that, it feels like the institution as a whole, the goal of it is to put space between you and your patients. So patients would call and they get a message center, and then I'd get these typed, that's changed, right? I mean, this is a while ago. Now they have an EMR, but I would get these typed papers in the morning. Patient called, this sort of like translation of what they asked for, but it was never really clear. And then I never had time to call them back. And then that time we had a newborn and I was pregnant and it was just awful. Yeah, it was not good.
I was listening to one of my favorite podcasts, 99% Invisible, and they were doing this episode on breaking bad news and how Dr. Bachman, who was in the same comedy group as a lot of the people in Monty Python, had this, this acronym for how to break bad news. And they're not doctors talking on this podcast, but they were trying to describe how, a doctor definitely needs the time to deliver bad news, specifically the topic of this episode. And they were saying like the national average that they found was 21 minutes. And I was like, yeah, what study shows that? Like, cause that ain't happening in primary care. And I mean, all of those things that you say, I'm so glad you said them because, I'm sort of playing devil's advocate because all of us, like you, me, and James have all been through this, like, what is this, right? Like, this is not what we wrote about when we applied to medical school. This is not what we thought we would be doing in a lot of our cases. And when you talk about that, it's like, here are people who can't afford what like you said, meaningful healthcare, but we're trying to provide that meaningful healthcare in fee for service. And it's like, but I can't, like, I really want to, I'm trying to, and I can't do that. And when you talk about, especially like, people might not know where Irvine is and, they might hear Orange County and think like what the old, like, I'm so dating myself, but like Misha Barton on the OC or whatever, like, but when you guys are, when you're talking about a culturally diverse population, economically, socioeconomically diverse population, it's like, that is so complicated. Like that's not, and that's even apart from the 15 problems that the person might have or the 20 medications that they might be taking. It's just having the cultural competence to be like, this is totally normal for this culture or so not normal. Or like the fact that, they're not emoting is like, not that they hate you as a doctor, but literally because they don't emote as part of that family unit or that culture. And so I think it's so crazy how we just go from residency into these jobs and we're like, all right, I'm ready to start. It's like, no, this is not at all what I signed up for. And so, but it's interesting too, because as you experience that, at what point did you think about like, there's got to be a different way to do my job?
Yeah, I mean, I think I have one experience that stood out in particular. I had a patient, super complex, and I'm running around and she was having symptoms. I don't remember the details, but she came back to me later and she's like, you told me that I was withdrawing from my medication, but I was having a stroke and you missed it. And I was just at that moment, I was like, my God, this is not right? The level of stress that I'm carrying with this and, reflecting on myself and my own health, along with my sense of purpose. What am I really doing here? I'm like standing into this terrible broken machine and just spitting out like not good care. And what am I being trained to do as a doctor in my first job? And that was when I was like, nope, this is not going to work. I can't do this. And it's heartbreaking because those are the areas that need physicians with heart more than anything. And it seems that if you go in there and you've got heart, you kind of get ripped up. It's like, it's tough. I hats off to people who stay there and work and they have great hearts and they do great things and they should be given just so much more to support them. So.
Absolutely. And James, as you see this transition that you mentioned in emergency care where, there's private physician groups that are being bought out. And then, there's some ERs now with no physicians, which is insane. And people don't believe me when I say that. I'm like, oh yeah, like look at this hospital, look at that hospital. But for you, did you have similar experiences, going into as a new grad out of residency, your first job, working with physicians, who are leading the group? And in that experience, did you also feel any like, I know you said like how you, doing trauma according to the emergency room, not like taking them to the trauma surgery base, but like what you were doing in the ER acutely, did you see yourself getting pressured to, see more or do things out of your scope or like do things under your scope because you were, in the same healthcare world that Emilie was in Irvine and Long Beach? Stay with us. We'll be right back. Have you tried an AI scribe in your clinic? Well, I've tried so many, and I can say Heidi Health is the best AI scribe I have come across thus far. With Heidi Health, I can create unlimited customizable templates for my notes to help me truly cut down on the time I'm spending charting. Template for pediatric well child check? Done. Template for weight loss management? Done. Some of my favorite things I've built into my AI template, beyond the general soap note, are having a list of actionables for our team to take after a patient visit, having the diagnoses listed, and creating an after-visit summary for our patients. Not only have I found Heidi Health to be the most helpful, customizable AI scribe so far, it's also more affordable than most out there. So try Heidi Health today and see how you can harness the power of an AI scribe for your practice. To get an entire month of Heidi Pro free, go to the homepage of mydpcstory.com and click on the Heidi Health ad.
It's so funny. You can make that a survey question, and then you could put the last one like all of the above. I would just circle that one. Yeah, it's pretty stunning, coming from, this sheltered world of residency, right? In academia. It's pretty simple. I mean, you're learning the medicine, and there were some logistics we had to learn in terms of, private attending and taking care of it. But pretty much in the academic centers, there were these bubbles of care, right? Where everyone was fairly taken care of outside of a few instances. Moving to California in a totally different HMO dominated world, it was flooring to me what I was having to do, like knowing which patient had what insurance was probably the biggest thing I had to learn and continue all the way until I left was the sticking point of the face sheet, the ER face sheet. What insurance do they have? And not because like I would treat them differently, but like if they needed to be admitted or I needed a specialist, like it was just this convoluted system where I had to transfer them to a hospital 60 miles away and the patient had no idea. And it's like, well, that's because that's your insurance. Like you can't be admitted here. It was just horrible. It was demoralizing, at the end of the day, I'm the face of this care delivery, right? Like I'm the one at the bedside telling them these news and, it was just hard from a systemic perspective. And then all of the other things, right? I mean, hospital-based care, emergency medicine, it's RVU based. So clearly the more patients I saw and, the level of care that I documented clearly would bring my RVU up and, profit sharing and all of those things. So it's all a silly game with our templates of review of systems and physical exam. And none of it translates into better care for the patient at the end of the day, unfortunately.
So coming from that experience, coming from the experience you had seen and, been through in New York, how did you, because I actually don't know the answer to this. Emilie, did you first learn about DPC or did you both learn about DPC? How did you guys find direct primary care? And then how did you choose direct primary care as your next venture into how to do medicine for our patients?
I remember the sequence of timing. So, and you could probably remember it better. So Dave Chase is definitely probably the first, his articles in Forbes about direct primary care specifically, he wrote extensively about it, was definitely one of those first moments. And then also you were looking for a job with Crossover Health, who happened to be potentially opening something in the area at the time. Well, and they coincided. I just don't remember which came first.
So I was at Optum after UCI, and that was interesting. They were
it wasn't Optum at first, so it was Monarch Medical Group. It was it was
a local one, and then Optum bought them.
Right. Yeah.
Yep. And they were doing this whole RAF thing, this whole risk adjusted factor. I don't know if you know about this. It was actually really, I was surprised it wasn't fraud what they were doing. And wow. And there's exposés in all the different news places about this whole practice, but they basically Medicare pays you more if your patients are sicker, which makes sense, right? I mean, it's good intentions. And so what they do is they set up a whole system to farm the charts for codes to make your patients, and they're not making your patients look sicker, but they are. I mean, they're trying to get different codes out to really beef up how much money they get. So it really was just so perverse. And I was just like, this is, again, we're not taking care of patients and there has to be a different way. So, And then as in the meantime, I'm buried in the clinic with 20 to 25 patients a day. So I'm like, okay, let's try group visits, hand me a PA and we're going to work together and we're going to be a team and try to do that. And that there's no way to cut it differently when you have to see that many patients. So it's like, there has to be a different way. And then we started reading Dave Chase and I was like, I have to work in this model where you get paid. My dream was like, I'll be the doctor for this company and I'll be the doctor for all these employees and it'll be right? It'll be aligned because this is how it's supposed to be. And so then I was like, that's what I want. I don't want to do any more of these jobs that are broken. And then the company crossover was the first one that we found that was local because I didn't want to start my own thing. I was terrified. And so I tried to get a job with them. They couldn't, we're not going to be local. They were like, you can move up to the Bay Area and go work at Facebook and we're not going to move. So James is like, you know what? We're just going to do our own thing. You can do this. Let's start our own business. And so that's why we did it. Because I couldn't find somebody else doing it I could jump in on.
There wasn't like a turnkey solution. Yeah. I mean, looking at the turnkey solution and none existed. And yeah, I mean, we've talked to countless people about this. I mean, at the end of the day, what's the worst that can happen, right? I mean, you're not going to end up homeless on the street because you couldn't, your DPC didn't work. Yeah, you could lose some money from cost of it. And you're still a physician that can be highly valued somewhere. So
I feel like we're scrappy in general, or maybe I shouldn't say scrappy, but we're survivors. There are some of us who are like, I'm going to be done with medicine now if I don't find something else like DPC. And I mean, even with a physician degree, it's like, you also realize that we are all, I mean, I'm not saying this to you personally, but it's like you meaning like the person who I was even was thinking about well, maybe I should leave medicine. It's like, you realize that you actually could be employed doing a lot of things. Like you could be a marketing person or work at, as a vice principal or work as a janitor. There's a lot of being from a Filipino family. It was like doctor, teacher, lawyer. There actually are more jobs out there than those three, but I feel that, that mindset it was like, yeah, I'm not going to do this. And I don't care what it is, but it's not going to be this job that I'm doing going forward. So it's very interesting how we have similar, I'm done with this. This is nonsense experiences before, in our cases, choosing DPC. Now, when you guys are reading Dave Chase's, his work, what was it that made it this is right. This is the model that I want to be in?
I just had this sense when I was trying, it was always about the money, right? So it was when I was at UCI, I was like, well, if we can just bill every visit 99214 or try to get these more complex codes in, because these are really sick patients, then you guys will give us half as many patients on our schedule, right? And they're like, no. You'll just make us more money, right? So then it's like, okay, well, no, that's not going to work. And then we get to Optum and it's like, okay, well, we're going to make care team. And it's like, okay, well, great. And now you need to find the RAF scores because that's where the money's coming from. So to me, when I was reading Dave Chase, it's like, oh, the money's coming from the patient. So if the money's coming from the patient, then everything else will fall in line. Now the incentives are aligned. So that just was so obvious.
Yeah, it was really, it's interesting. It's not really reinventing it's not anything new. I mean, this is the way it was. We just forgot, right? So, it took him to kind of bring that to light and bring it into the context of the modern era to describe how it could be again. And yeah, it's super simple. It's incredibly different than what you traditionally see, but it's nothing new at the same time.
And as you found that crossover was not, going to be local to Irvine and you weren't going to move to be a doctor at Facebook, how did you overcome the dude, I've never opened a business before. What the heck am I going to do? How did you get from there to welcome to Halcyon Health?
Yeah. I mean, first I went and brought my boss lunch, which was interesting. There were lots of interesting moments there. My boss kind of, patronizingly took the lunch and I was like, I'm going to tell you about this great idea. You're going to love it. We're going to open a DPC here at Optum. I'll spearhead it. You just give me the tools. I'm going to make this awesome DPC because I still didn't want to take the risk because that's who I am. And he was like, this is a terrible idea. He's like, these people go concierge and they always fail. And it's like, no, you didn't hear anything I said. So I was completely sort of dismissed out of hand. And so then so it's him. So he did it.
Why not?
Yeah, he's more a risk taker. He was like, oh yeah, we can do this.
Yeah. So. No, yeah, I think, if you go to the nitty gritty, you want to go to the nitty gritty, right? I mean, you do your, financials, your home and your personal, I should say, and figure out what you need. We're in a very special, unique situation, right? We're both dual income physician families, so we could make it work. And I worked full-time in the ER for the first couple of years while she ramped up her practice. But yeah, I think your question was like, in terms of being a business owner, like the steps to getting there. None of us have any training in business. Like we have no background in it whatsoever. So it really was just Googling things. And to be honest, the community that was out there, we spoke with, Newhoffel, Rob Lampert. I mean,
Yeah.
We spent so much time with them and they were so gracious, just mentoring and just asking, answering our questions. And really at the end of the day, it's incredibly simple. The steps to getting there, it's a different language and it's different like stuff we never were trained in, but really the steps, if you just take a little bit of time to go through it, it's really not that difficult.
I think every doctor who's starting a DPC needs a James voice in their head because he has all the self-efficacy, this sense of like, oh yeah, well, it's simple. You just do it. Like if he,
like the clean version or the explicit version, because there's two different voices that can happen.
Anyway,
there's only two. Like, God, James, come on.
Well, there's more.
Amazing routine of making coffee for a while where he'd like grind the beans by hand and then weigh them out. And I'd be like, my gosh, he'd be like, well, it's just really simple, and he's right. It's like, if you just take the steps, but if you look at it from the outside and you watch him make a cup of coffee, you're like, that's insane. That takes up so much work. How are you doing that? But then it's done and you think about it, well, it actually was pretty simple. Like,
the coffee is pretty good.
And I have some kick-ass coffee. So
nice. It's awesome.
Yeah.
Tell us about your strategy, because I totally want to call you out on this because I love it. I emulated it when I was getting ready to leave after I had given my my notice that I was going to quit. But what strategy did you use to not necessarily tell patients where you were going to be, but how you could get them to follow you or find out more information about you by quote unquote opting in to what you had to say online?
Yeah. So I had found many times just referring my patients to different websites for information at my old job. So then I was like, well, I'm going to start my own blog. And in the blog, I put why you should get a pap smear every 3 years instead of every year, and why you should put on sunscreen. And here's different sunscreens. So I would tell them to go check out my blog. And then when we switched over, we just turned the blog URL to our company. So it just kind of like when they went to the blog, it all of a sudden was our company.
And this was a long time ago. So now there's all of these different channels now for like media, right? I mean, like this, for instance. So I can imagine any physician now, a young physician with a voice, can just be out there and having their voice independent technically of their employed position and being like, yeah, this is my personal thing, and whatever they do later, it's, can be transferred.
Absolutely. And there's ways to do it. I know people are so worried with, if they live in a state with non-competes that are enforceable, or, they need to practice outside of their certain radius or whatever. When you have, like similar to what Emilie did, when you have an option where the patient is the one choosing to follow you rather than like you giving out, this is my email address, let me sign you up to get my email later on. I mean, that you take that all away. And if they're engaging with you, they could engage with the people outside the marketplace who are like asking you to sign a petition. There's no, like, that's on the patient or the potential patient to be able to follow whoever they want to. So, I mention that because some people are thinking like, but how do I let my patients know, because I'm not supposed to tell them? And it's like, well, do something like Dr. Scott did. And then look at them now and look at you and James, like you guys are super successful, and we'll get to how you've grown. But it's a great way to really, I think, practicing also, like doing a blog to me is also practicing being a DPC owner, because it's a way to like think about how you're going to engage with people on different levels, including how you can be their doctor when they're not necessarily in front of you face to face. So I really loved how you did the blog. Now, James, when you and Emilie were having these discussions, you with your multiple voices and taking those next steps, step by step, what were some of the first steps that you guys took, or the most important steps in order to open the doors for day one?
Yeah, I think one was figuring out, we decided pretty early, we wanted a physical space. This wasn't going to be remote or mobile necessarily. So we're looking for a physical space. I think that was probably the highest thing. In parallel to that, all of the things of registering, your business, figuring out your business name, like going through that checklist was happening simultaneously. But I think in terms of stress and importance, I think that was the highest stress in the beginning, was deciding the physical location, how big, where we wanted it. We got lucky. I think we found a place pretty quickly, but that was, I think, for me, at least, the highest stress component was the location.
I feel like a high stress component for a lot of people would be hiring. Like, again, this was James, right? I was like, I'm going to be in the back of someone else's office and not hire anybody because it's, I'm scared. And he was like, we're getting an office space and we're hiring somebody. And I was like, but, and we did. And we were so lucky to have one of the front office staff at my prior job at Optum was going to quit. She was miserable and I knew she was great. So we snatched her up and she's still with us here now. So that could be potentially very stressful, hiring somebody. And, we were paying her very little in the beginning. So she really made the leap, out of a just belief that we would succeed. And then just knowing now you're responsible for somebody else's money and you haven't started yet, that was just a lot.
Yeah. I mean, I guess you can frame it that way, or
see,
or the possibilities and just having the confidence, like, hey, you're going to make this work, right? Mindset. I think this is an example of mindset and how thinking of the potentials. And, for me, I'm always thinking like, where's the exit? Like, where's the emergency exit, right? Like, that's my emergency medicine hat on. Like, what are the bad things that can go wrong? I know where to go, but that's not what I'm thinking all the time, right? I'm focusing on moving forward, but I'm also cognizant of like, okay, well, this can happen. So I have these parachutes that we can deploy.
And thinking, in that line of thought, did you prepare, like you said, James, how you were working for 2 years straight in the ER so that Emilie could do this, but is that how you primarily plan financially for whatever happens with the DPC?
Yeah, pretty much. Yeah.
We sold our condo and bought a house that cost less.
That's true.
Like we moved to a different neighborhood and that money that we took from that, we put into the DPC. So that was our investment money. And then I didn't have a salary. So we were living on just one salary for the time for a year.
Yeah, for about a year. And, once again, this is a specific circumstance. I have the flexibility of asking for more shifts. So this was pre-COVID and, I could work really hard if I needed to. So I felt there's all these levers I felt like had the privilege of being able to manage financially during that time.
And then going forward to Halcyon Health DPC is opened and it's day one. Did you have patients on day one?
Yeah, we had an open house that I pushed really hard. I actually did get a list of patients and sent it out to them. And we had a good showing. And I remember one patient coming in who appreciated our relationship, and that's why she showed up, but she was heavily skeptical. She was like, I can't afford this. Like, this is going to be too much money. And then we told her the price. She's like, no, that's not it. And we're like, yeah, that's it. No, I'm not on Candid Camera. I remember her saying that. I don't know if anybody knows what that show is anymore, but I remember that show. And, we're like, no, this is real. And so it was kind of like that experience. People were just shocked that that's it. That's all you're charging. And she's still in our practice, right? 7-8 years later. So we had, I think, about 70 to 80 people in the first month sign up to the practice. Yeah. And I remember we put up the website. And I had 3 people sign up right away, 2 of which were my patients from before. And I was like, oh my God, just so excited. And then one was this one patient and we were like, she made a mistake. Like, she doesn't know what this is. Like I was just not confident, right? Who is this person? She doesn't know, just randomly found us. And she's still in our practice, 7 years later. So just lack of thinking that you have something to offer was my biggest barrier, right? It's like, you need that, you totally can offer something. So
that's awesome. And I love that you said that, because that voice, I think we all have multiple voices in our head. And when it comes to the self-doubt, it's a real thing, especially like James, how you're talking, we are literally trained in this breadcrumb. You follow the next breadcrumb. And then it's like, what am I actually worth? It's like, you don't even think about that because that's not your right to think about that. You do what you're told. Like, this is the next breadcrumb that you follow is so ingrained in our training and just how medicine is done. Like, there's a hierarchy of you report to your second year, who reports to your third year, who reports to the attending, yada, yada. So when you were thinking in that space, James, do you remember any conversations to counteract that when Emilie was like, how is this even happening? Any of those self-doubts? Like, how did you guys get through those conversations in that first year?
Well, I mean, it was pretty easy, right? I mean, it's what's nice is there's such this simple reward system, right? People just sign up and there's no refuting that, right? Like you can have the doubt, but if they keep signing up, I mean, it's just harder to doubt it once the numbers start coming up. And yeah, they're great patient experience. And then you get to meet the patients and why, right? You learn the why they joined your practice. And then I think for her, that probably, and I don't want to speak on her behalf, but yeah, they appreciate what we're doing. They get the alignment of, how we're practicing and aligning with them from a patient perspective. And, I don't feel like I needed to counteract it by actively doing anything outside of just refocusing hey, patients are signing up. It's going to be okay.
And Emilie, as you built out Halcyon, given that you had training like your integrative fellowship with the Andrew Weil Institute, did you specifically craft your clinic so that you had so many patients a day or so much per visit in terms of amount of time so that you could start incorporating things that you might not have the opportunity to in your previous jobs?
For sure. Yeah, absolutely. I mean, it was from the beginning, it was mood, sleep, nutrition, exercise, hitting on those 4 points every time. Everybody got an hour at least. And we have a doctor who started with us a couple of years ago who, started with an hour per patient. And was like, you know what, now I need an hour's not enough. I need 90 minutes. So certain patients we would give more time to, but I think, that freedom is just amazing.
Yeah. I like to you mentioned the breadcrumb thing, and it's like, instead of following breadcrumbs, you get to be the baker, right? You're baking the bread, and it's just so it's so gratifying. Yeah. It's nice.
I love it. As you guys are talking about these, even how James, you were talking about how this is not new. This is how medicine used to be. It's this is totally you can hear now that I am clearly the mom of 2 young kids. Cause I'm that's just like Ryan, the last dragon, the world is dead. And then it woke up when all, when what is the name of the dragon, came back to I'm thinking of random, weird thoughts over here. But when you talk about that, I'm envisioning the gingerbread man and Puss in Boots. And so anyways, this is not to do with DPC. It's totally to do with momhood. So Emilie, when you look back, and James, when you look back on your guys' experience in those first 2 years, James, did you plan any specific ways to be able to transition over? And Emilie, did you plan in any way specifically to prepare for James to come on?
Yeah, our plan, so financially and business-wise, was a 5-year window. We give ourselves 5 years, 5 years for her to fill up her panel, and then I will transition out and join the practice. I mean, we were super lucky. A year in, we're oh, I think I'm ready now. I think, I was burnt out, and financially the growth was such in a place that we could really start doing that. Me preparing clinically, once again, this is a unique situation. I'm basically, kind of in my mind, an intern, right? I'm asking her a lot of questions on things. It's just not part of my training. I mean, it's 2 different specialties. And for me to say I'm just going to do, family medicine now is, that's not possible. So the one thing I can do, the one thing I love to do was the patient part, right? Sitting down with a patient and interacting with patients. And that's regardless of the specialty. Yet at the end of the day, that's the heart of a primary care relationship, is just being able to listen and engage with people. Emergency medicine is different. I had 10 seconds to gain somebody's trust, right? So now I have a little bit longer, maybe 12 seconds, but it's the medicine part is still, I'm still learning every day. I don't know, what's that rash? And so I'll pull her in for the rash.
He's reading so much. He's coming up to me and telling me how to manage things.
A lot of up to date. So for me, a lot of up to date, as well as her, basically mentoring me in terms of the clinical care. Yeah.
I'm going to put a shout out there. If you're a DPC Alliance member, definitely check out that up to date discount, because that's what my husband and I are using since we don't have access to it. They're here shaking their heads. It's yes, there is a discount.
Yeah.
So Emilie, how about you in terms of preparing? Because like I asked this, especially again, going back to my husband and I are in this place where he's coming and joining on. And I'm like, okay, I got to get this ready now so that he can come on successfully. Like, given your experience being a DPC doctor exclusively, did you prepare the clinic in any particular way? Or would you advise to other people, this is what I would do, or like, these are the things that don't really matter to be able to bring on James?
Yeah, I mean, we honestly, bringing on James it's more like bringing out James from our home finances, really. I mean, that's truly what we're preparing for, because bringing James into the business is like he's helping. So there's nothing to prepare for. He's just coming in to help. So no, it's really about just getting your finances in line. Like how expensive is your house? Did you buy a new car? Do you want to go like do fancy things? So if so, and you got to just make sure you can afford to be off that income. We, as I got busier, I think more in the early years, it was prepping. When do we hire our next medical assistant? So we hired a second medical assistant 2 years in.
1 year later.
A year later. Okay. Yeah. A year later. So, and she was, because I was doing all the blood draws and the shots, I'm like Googling, like, what's an IM shot? So cute. Like, how do I angle the needle? I mean, we don't learn this stuff. So spinning the blood, right? Pipetting it. So all that stuff, we needed to hand that off so I could work on growing my panel even more. But yeah, I mean, bringing James on was not, I don't know. He was just there. Yeah.
I love it. That's so like a spouse thing to say. Like he's just there. I love it. I will shamelessly say that, when I was starting out, I was like I'd given injections before, like, sub-Q, but like, the inner voice in me that was like, oh my God, but you got to make sure you review it, blah, blah, blah. It's like, I remember I bookmarked the like how to give a Prolia shot, like on my, yes. And I was like, okay, I'm going to watch it. I'm going to watch it again and again and again. What's another one? Shingrix. That's another one where I was like, okay, you take vial 1 and you take vial 2 and like, okay. Yeah. So I totally can relate. Oh my God. So when you guys are talking about adding an MA, how did you, like, what was happening at Halcyon where you're like, now is the time that we need to start adding somebody on?
It was pretty quick because like she was saying, I mean, she's did all the blood draws, all the clinical stuff, right? And I think you were just really busy.
I think it's so funny how I don't remember. I feel like that must have been it. I must have been so busy and we could afford it. We could afford to pay someone it was still not about me getting a salary, but we could afford to pay another MA.
And that's just in the background, seeing your growth curve, right? Like you're just seeing that just patients are continuing to sign up and seeing that it just made sense to invest. Yeah.
We wanted her to start a certain time and she didn't come till like 2 months later. And we were kind of losing our minds. Like we were busy. Yeah.
That's awesome. That's, it's busy is a good thing when it comes to DPC, especially when you can still practice the way you want to. Let me ask you there, because as people have come on to the practice, especially in this early period, the first 2 years, what was your biggest way of marketing? And if it was word of mouth, at what point did you feel like, whoa, okay, this was the magic number for us? And then going from there, did it explode? I asked that because in Irvine, given that you guys are in the OC and there's, UCI and all the major hospitals with the billboards, and I don't know if they had Super Bowl ads too, but versus Halcyon Health, how did people find you? And then what's been your biggest way that people have joined have learned about the practice?
I think it's word of mouth, honestly. And we did like some webinars, but primarily for mostly our patients. I joined the Chamber of Commerce and kind of did my networking thing there, got some patients through there. Reflecting back on it, I think, and I'm sure you've talked about it and people are talking, there's these influencers, right? There's these evangelists, not evangelicals, and evangelists.
Very different thing.
Very different, who happen to be real estate people, who happen to know so many people. And, we have those people in our practice that have just helped exponentially spread that by word of mouth. And then along the way, so some small businesses, like part of it is just luck. Like people just knocked on our door and said, hey, we looked up DPC and you're one of the few in the area. And yeah, it's been that. And then at a certain point, like, and I can't give you a number, but after a couple hundred, it's this self-sustaining, word of mouth after a particular point.
And as people were joining, did you have a practice that was just, like self-selecting to be a full scope family practice, or did you see more of a certain demographic, like older, younger, pediatrics? How was your practice as you grew initially?
Yeah, I mean, I would say the real base demographic are people between 30 and 50 with kids.
Yeah, that's a big chunk of it. It's interesting. It's people really investing in their health, if you think about it. And that's how we frame it to our patients as well when we review their medical history. But, people who are really, that are people who are just traumatized, right, by the system for various reasons. And so they're just looking for an alternative. I mean, those are the two kind of segments that we see, but it's definitely the young families, the professionals, and, the convenience factor. So and then we have, and then it's interesting, they bring their family members along the ride, right? So it's an interesting middle ground. You have these, 30 to 50, couples, and they bring their kids, and then they have their work colleagues they spread to, and then they bring their parents, and then their parents' friends. And that's how that kind of grows from that perspective that we've seen.
Awesome. And as you guys were doing this, growing the practice, James coming onto the practice, and you had, like you said, Emilie, you had already a newborn and you were pregnant before you started DPC. In the first few years of the practice, how old were the kids, and how did you guys manage as a family to be doing family, as husband and wife, as mom and dad, as well as doctor and doctor?
So they were, they were 7 and 5 when we opened our practice. So, and we were working on, kind of the transition for about a year before then, doing research, maybe a little, more than that. So, from the ages of 3 and 5 to 5 to 7, we were starting to get this warmed up and ready to go. I said, earlier about balance, right? I mean, part of this has been about finding this balance in our household. And that's really been important to us. It's actually been the focus of, we have one practice, and it's an incredibly robust practice. And we've chosen not to take in the personal time to make this 10 sites, right? I mean, that's just a decision we've made, and incredibly happy to, just have a lot of time with our kids and with each other. And it's been really amazing.
I don't know if you talk to, some of your co-residents or, even people in medical school about what their lives are and how they're spending or not spending time with their kids. But it's crazy how you started with the kids being 3 and 5 and in that age group. And then now, they're almost teenagers, or one is a teenager. And it's what could life have been like had you not been able to do what you guys did, right? It's just so awesome. And it makes me all emotional, right? The last person I recorded with is Dr. Mina Julapali, and she was making me all emotional too. But I just think that what a gift that you guys have for yourselves, and what a gift you have for your entire family, especially your kids, that you're able to look back and say I was able to do these things with you. So when you talk about, James, going back to how one of the biggest decisions in the beginning was space, you guys have transitioned to a new space, and the website's been fluffed up. It was gorgeous then, but it's gorgeous now. How did you guys decide? Emilie mentioned staffing, but how did you guys decide we're not going to do 10 practices, but we are going to go into a new space?
Yeah, I was literally running down the hall in our building asking the sleep center next door if I could use their room. So it was time. We were operating out of one room and it was not going to work. So so we needed more space, and we initially were just going to blow a hole in the wall of the building where we were. And then we got a better offer for a much bigger place, more space than we needed. And the price was really good. So here we are. And it was so worth it. I think that's one thing. It's if you already have momentum, channel your inner James making ground coffee and be this seems pretty simple, right? Things are moving forward. They're going to keep moving forward. So get a little bit more space if you can.
Yeah. It felt like that pretty fast, right? Early on. So we signed a 3-year lease in the first place. We're currently in year 3 of the 5-year lease now. But after year 1, we're we need, we're going to need more space really soon. So luckily it was a 3-year lease. And yeah, at this place.
And can you describe your space for those people who haven't seen pictures on your website compared to your, like the one room situation? I guess it doesn't really need comparing to, but how does your space look like now? And now you have Dr. Seymour and Dr. Susskind. So how does everybody work? Is everybody in the building at the same time, or do you guys stagger?
Yeah.
There's one day a week where everybody's here. And I have a chiropractor friend who we met initially, and then she subleased with me in our first space, which was a great idea too, to bring more traffic to your office. And she's hugely supportive. And so we would refer each other patients. So that was great. And so she's still subleasing from us here. So we have 4 rooms and 5 rooms and a separate lab for Nancy, whereas before we had 1 room. So, and Nancy's the clinical MA. So she has her space where she can draw blood and all of that. Before, she was doing it in the waiting room. And so people would pass out and then they'd be laying on the floor in the waiting room. And we just put like a screen in front of them and you'd just see their feet sticking out. It was really
just really like IKEA screen.
It was like, great. Yeah.
Nothing to see here. Don't worry about it. We're good. Welcome to Halcyon Health.
If you need something, Target can send that, deliver it to your door in about 2 hours. So you're good. Oh my God. That is, oh my, I have no words for that. I would not want to be the patient being like watching the screen, being the patient. Oh my gosh. Oh. So let me ask you this, because as you have grown, specifically, you have 2 MDs who have joined your practice. And so whereas, there's other clinics out there, there's other DPC clinics, who are specifically looking for physicians to join, and it's quite difficult to find physicians. How did Dr. Susskind, Dr. Seymour find you guys and decide, like, this is amazing, like, I want to work here?
How did that work? So it's, the universe is funny. It's just, it's such a small world. And there's this one person who contacted me cold email, just like, hey, I'd love to meet you. I've heard about DPC. Great.
Her name's Jess.
Yeah, her name's Jess.
She's a physician.
Yeah, pediatrician, now in public health, and super gung. She reminds me of you, actually, right? And she's just gung ho. I just want to learn about this. Like, what are you guys doing? I'd love to do this in pediatrics and serve county population. So we had, she's amazing, got along well. And she's like, one of my best friends, she'd be perfect here. So we emailed her and she said, thanks, but no thanks. This sounds nice, but not interested at the time. And I'll take it to you because
then I was like, I want to marry this girl. So I kept emailing her. I think I emailed her 2 more times. And I just I was like, I'm just going to email her again. And I was like, every time I think about hiring someone, I just keep coming back to you. And she was like, okay, yes, I'm going to come over and talk to you guys now. So then she came on her birthday and spent the day and just looked at our practice. And then she was like, you know what, I'm going to do this. So that was that. And then Dr. Seymour is super interesting. One of Dr. Susskind's patients said, there's this doctor at UCI who I really love, who would be such a great fit. And Shay told me that. And I'm like, I'm calling right now. So I called over while she was in the middle of clinic and I was like, hey, I'm calling to recruit you. Like, do you want a job? And she was like, what? And I guess she had been looking. Actually, she looked at a couple of different practices. She was trying to figure out where to go because she didn't want to do the grind anymore. And so I called at the right time and she's a perfect fit for the culture of our practice. And
I think, the lesson to me, I guess, just hearing this, it's a mix of luck, right? Like just having, people in your life that come into your life and these relationships and connections that you maintain and the work, right? Like, I mean, she hustled. She's just like, I'm going to call, I don't know who this person is, but she sounds amazing and her video is amazing. Like, let's call her. And so instead of this passive, putting out job opening, come find me, that can work. I'm not saying that won't work, but I think there's just something more, especially when for us, the culture is the number one thing in our practice. It's people and relationships. So, when that's the most important thing, you really have to rely on your network of people and to seek out those relationships.
And we did put out ads and we did interview a bunch of people.
It was not good.
Yeah, it's challenging.
It's like Mary Poppins, man. This is crazy.
Yeah. Yes.
That's
a good one. Look at your mommy references. Yeah. That's a good one.
Also a Julie Andrews fan. But I just love that though. And, I think that the more and more people hear your story, people hear all the stories on the podcast, the more and more we talk to people about how wait a minute, you're telling me I can do that? I can do exactly what I signed up to do when I became a doctor and like just dedicated my life to take care of other people. Like, that's incredible. And I'm not having to do it for only people who have 7-figure salaries. Like, that's incredible. So I think that the more and more this happens, the more and more we get the word out, it's like every time somebody hears about it, I mean, like even just within your practice, like somebody had a friend who decided to be, that this is, perfect fit. And then their patient knew a person, it's like, that's awesome. And so I think this is where the fact that you focus on relationships, it's interesting. Dr. Shannon Scholl, when I was talking to her, she's a gastroenterologist who was previously on the podcast in Raleigh. She said live time, like, I didn't think of it. This is like relationship-based medicine. And it's like, yes, like absolutely. Because I found that at Big Trees MD too, that like the patients who've joined, they will tell the people who, value healthcare in the same way. And so they are the people who then join after them. So I definitely would say, also something that I love is that like you went from this place, Emilie, of like, oh my gosh, like I don't necessarily have the best confidence in like, I'm going to call my next work wife. Like, this is awesome. Like, I love it. Yeah, that's incredible. Now, how is it structured at Halcyon in terms of when you bring a physician on, are they a 1099? Do they own part of the practice? How does it work?
No, it's a 1099. It's simple, straightforward. Yeah. And really, the arrangement is, there isn't a set number of patients technically like they have to see. You asked earlier in terms of the logistics of the workflow, there's no 9 to 5, like you have to be here 9 to 5 kind of thing. It's the expectation, like you have to take care of your patients, right? If you're at home, if there's nobody on your schedule, like that's great. Like check your messages and take care of your patients. So yeah, it's a straight 1099. There's a percentage split in terms of they collect on the membership fees. The practice collects the rest for overhead. And yeah, that's it. They're independent contractors. So technically they can work wherever else they want. And it gives them flexibility as well.
When we hired Dr. Seymour, I was trying to tell her, take one new patient a day. And she was like, well, I could do 5. I mean, she's very experienced. I can do 5. I think I'll be okay with doing, a bunch and like, and now 3 months later, she's like, my gosh, I thought an hour was going to be so much time. And now I'm just like, I don't understand, it's just a very different lens on things. So I think helping mentor people, even very experienced physicians who know medicine really well, to kind of understand to take it slow. And I think I really like the idea of hiring people and not holding their feet to the flames. Like you have to take 600 patients, I think it's really nice for them to be able to feel it out and see how they want to balance it and what it feels like to them, because they don't know. And I don't want to hire someone who then becomes miserable and quits.
Definitely not, especially if you go through all of that work mentally, also preparing for like, we're going to have another doctor join the practice. And then it's like, it falls through. That it can definitely be, one more thing that you don't necessarily need to have on your plate or think about if you prepare for it differently. And that said, when you guys were talking with Dr. Siska and Dr. Seymour to join, did you have any discussions because they're 1099s about like, this is what we have on the waiting list in terms of people as you onboard them? Or how did you, have any financial discussions with them? Because they're also going from, even though one of them was like was looking for something else, like they're going from a fee for service model to a different type of model where we work for our patients.
Yeah, I mean, financially, there's risk involved, right? And so, one of the things we value is just transparency. So, here's our wait list of patients, right? And here's when we first started collecting it up till now, here's how many. I don't know how many are going to follow through and actually sign up after we open up the panel. We're all hoping, I mean, the one thing that's reassuring is we're both aligned on this, right? I mean, we both want you, the new physician, to fill up because it benefits everybody. And so part of the discussion too is like, hey, if it starts slowing down, clearly we can rethink our marketing besides word of mouth. Like, are there things we need to do? But yeah, I mean, it's very transparent in terms of laying out, here's what we have to potentially offer. Here's clearly what potentially you can make if, here's the trajectory. So it's pretty clear the potential. I mean, they have to be comfortable with the risk that like, hey, maybe it slows down, maybe it might not pan out the way we're describing. It's not guaranteed. And, it's diversified. And there's this whole nother discussion, right? Employers and how does that play into account? I mean, that could be an opportunity to fill up somebody's panel momentarily, and hopefully that would sustain itself as well. But yeah, that's how
when we hired Shay, we had a big employer contract that we had no idea what was coming, but they basically were like, oh, sorry, our thing dissolved and we're not our whatever benefits thing. So we lost 200 patients that we were going to give to her. And luckily Shay is, she wasn't angry, and she grew really fast too. But
this was actually COVID. She started in COVID.
She started in COVID.
Yeah.
So that was a good lesson learned though. I mean, you really, when you are bringing someone on, that language of okay, well, here's what we think is going to happen. And we're not making you any promises, right? You're still going to have to hustle.
Right. And the way we structured it there, we have a base, everybody's structured differently, but we have a base monthly compensation and then a certain amount after you reach that level. But once again, every DPC can structure it differently.
And James, how about this? When you came onto the practice, because I'm assuming you guys are an S Corp, just like Big Trees MD is, how did you join? Did you guys split ownership of the business, or are you a 1099 as well?
We're split ownership from the beginning. Yeah. From
the beginning. Gotcha. Okay. And did that have did that throw any complications with regards to your contracts? Because for example, my favorite portion about fee-for-service contracts that I don't see and I don't hear from in your guys' contracts is exclusivity and you can only work for us. And if you work anywhere else, we own your money. That's one of my favorites. I have more.
So for me, it was an issue. I was a 1099, so I had my own S Corp as an ER doc in California. And then my insurance contracts through that group didn't resolve renew after I left. So it was pretty clean.
Love it. And how about you guys are actively, and I cheated a little bit because you told me this when we prepped for the call, but you guys are actively looking for a new physician. So how has hiring been? How has this process now changed now that you're on your third physician to be hired at the practice? And what are you doing, or how are you looking for that person, given how the last two physicians joined by this word of mouth?
I'm anticipating it's likely going to be the same. Once again, I can't say enough, the cultural fit it's got to be dialed in, right? I mean, and so we're actively looking in the sense that we understand it's going to take time, right? If it happens tomorrow, we actually don't have a position today to offer, because Dr. Seymour still needs to fill up first. And we're seeing that she's probably going to fill in 12 months, hopefully. And so the whole process of meeting somebody or once again, developing relationships with multiple people to find that next fit is going to take some time. So that's why we're openly putting it out there that, we expect to hire another physician in the near term.
And what about residents? If people were in 2 years, I'm going to be graduated from my residency program, and I would love to work at your DPC or another DPC. What are your views on having someone coming out of residency to join at Halcyon?
I think what we always say, if it's a good cultural fit, if their values align with ours, I don't care about experience or, none of that. I mean, of course, HR, age and gender and all those things don't matter. What matters is, and it's really true. It's do they fit to the culture of our practice?
Yeah. So, and just take good care of patients. You're good at building relationships and cultivating relationships. And the medicine is, that's the base too. But at the end of the day, it's really got to be able to connect with people. And residents is great. That'd be awesome.
How do you guys go about, you said you interviewed multiple people, how do you guys go about your interview process in terms of the favorite questions that you like to answer or you like to ask, or the theme of questions that you guys have to try to figure out oh my God, you're my next work wife?
Yeah, I think, hearing a physician talk about how they want to take care of their patients. There are maybe some buzzwords that I hear, with Dr. Seymour, for example. She had this video of her talking about what she was doing at UCI, and it was yes, that, right? So I got to figure out how to put into words what that is. But it's really about what is your juju around the patients? Who are you with your patients?
Yeah.
Does that make sense?
Yeah. And I think part of it is it's kind of, gosh, it's hard to verbalize, and there's a way to do it. But it is like when you meet somebody, right? There's a chemistry, there's a body language, there's a sense of purpose that's communicated to somebody. And it's really, it's not tangible. It's, you can read the buzzwords, and you mentioned the word buzzwords, like we can say the buzzwords and somebody could say those buzzwords to us. And it's like, well, I don't know, like, you just feel it when you can see it in their eyes, when they talk about certain patients or their experience or what they're looking for. That's something that just pops out to us. I think that's really valuable. Yeah.
I love it. Someone said to me the other day, they were like, "Oh yes, that's right. You speak in hugs." And I was like, "Yes, this is true. Like I do like a hug." Oh my gosh. Now tell me about, we talked about the plans to, potentially re-sign the lease or move into a new space. If you were to go down the road of a new space, would you guys ever consider having Halcyon Health in 2 locations? I know, James, you said you didn't envision 10 locations, but if it were harder to find a bigger space, would you ever envision going to 2 different spaces? Why or why not?
The short answer is yes. Then it's just the financials after that, right? It's just projecting growth. And then clearly at that point, we'd probably have to take on capital with a loan and build that out. But yeah, I mean, going back to how we started, we bootstrapped this. So this is, at the end of the day, we own this, and there's, we don't owe anything to anybody, which has been really nice. But at some point, if we do want to grow, that would be the next step. And that's something we're actively thinking about, the 5-year, the 10-year, what do we want as our kids grow, right? I talked about this balance, and this balance is always recalibrating itself. So 5 years from now, our kids are, they're going to be going off to college, right? So it's kind of like
that can't be right.
or not. Maybe they're just going to travel the globe with a backpack. So either of the two. I'm very bearish on college, and that's a whole nother discussion. Yeah, I think, whatever they choose to do, they're going to be very different people than they are now, and their needs are different. And so how do we see ourselves in that light professionally? And yeah, it's really fun, exciting questions that we haven't answered yet.
I feel like we're more open now to growing faster than we have been in the past, just because we have this security of what we built here, and just that confidence. I'm no longer terrified. I mean, I'm still terrified, but it's different.
And one of the things different, we haven't talked about this, when the retail versus employer kind of group, we're incredibly diversified, right? We've built this practice, and we have employers and some employees, but it's just, it does feel very stable, the stable core of just diversified patients, and they're not all just going to leave. So it's a nice place to be.
I think that's strategically a very smart way to approach your practice, because I think there's another doctor. I'm hoping to get him on the podcast to share his story as well. But I believe he had 300 people in his employer group, and then the employer, took all of those agreements away, and then there were, 300 to 0 in one day. And so, people like Dr. Ken Richter are working with other DPCs to, have an employer send their employees to different DPCs, so that give and take is not so great. And I know we're recording this before and it'll air after, but I'm very excited and fortunate that I get to see you guys at the Rosetta Fest in Chicago, because that is, a whole place of people who are, they're associated with employers. Their employers are having, all of these employees looking for good healthcare, and there's not necessarily the knowledge of who's the DPC doctor who could take care of, these patients. And so I'm glad that we're, the 3 of us at least are joining the other doctors who are going to be there to discuss oh, you're looking for that type of healthcare. That's the type of healthcare that we do, and it's there's ways to grow with employers that, some people might be oh, I will never work with employers, because that's how I was back in 2019. I will never work with employers, because what happens if, 200 leave? And it's and Dr. Scott is still alive today. It's okay, So, and Dr. Suskin is still at your practice and full. I mean, on your website, it says closed to new patients. Yeah. So it's it'll be okay. So going forward, in terms of, you talked a little bit about your 5-10-year plan. For those doctors who are thinking about DPC, whether they be in medical school or residency or already attending physicians, do you have any last words or advice for those people who are thinking about DPC or figuring out who would be a good practice to join?
I just had a phone call a few days ago from this medical student who's like a dynamo. Her name's Siri. In case anybody wants to hire her in a few years, I might get to her first. But she is doing her family medicine residency in Utah, and she worked with me here from UCI. And she is gung-ho DPC. And she called me and said, oh my gosh, she just finished her intern year. She's like, this is awful. She's like, I can do it. I can do the 12 patients in a half day. And I'll finish my notes and I'll check all the boxes and I can play the game. She's like, but I don't like this. And she started asking me questions, which are so interesting about like, well, shouldn't I just take a job? Like, I can't just go straight out and do DPC. Like, I probably need to take a job because I need to like make money before I can do my DPC. And shouldn't I be like, doing that first? And what should I be doing? And I was, I felt like, oh my gosh, like she's already getting sort of like losing her confidence or I don't know if brainwashed is the right word, but she's losing her confidence that she could do this because she's so in the system. So just that reminder to those people that, you can do this. People do this all the time when they come out of residency, and you just have to have your James voice of like, it's really just like you grind the beans, you put you do the steps, even though it's like so much harder.
Gotta weigh the beans first.
Okay, see, so much harder than just going to Starbucks, but like you just take the steps and then you're going to have a much better life. Things are going to be so much better. And so, okay, so you give up $200,000 1 year. So in a salary, when you could be building this thing that's going to come back to you in spades if you own your own practice. And then if you have a DPC that's local to you and you really don't want to be a business owner, then, oh my gosh, find that DPC and go talk to them and go see if you're a cultural fit, because they really are different. Different DPCs feel different. And so what is the theme? Like, what's the flavor of that DPC? And is that what you want? And if it's not, then go start your own. Don't be afraid. Don't let the system make you feel like you're not powerful.
Love it. And James, how about you?
I'll use my water boy voice. You can do it.
Oh, no, I feel like there might be something wrong there now.
Really?
Like 2023 is water boy.
You can do it.
Is it? No? I feel like there's things there that may not be okay.
The movie is probably really bad, but that quote is not. No, I don't think that's offensive that you can do it. But, in all honesty, I think the same as Emilie. I think there's a place for you, right? I think whoever you are looking for something, whether you're a future business owner, whether you want to partner with a DPC, there are similar-minded people who, have created these spaces for both, physicians and their patients, where it's just, this, harmonious place where you can practice medicine and feel like a normal human being that's helping them, right? And it's a wonderful place to be, and you can find it. I think one thing to also just highlight, as simple as these things are, it also isn't necessarily easy, right? So I think, Emilie worked her butt off like in the very beginning, as you have, as every other DPC has. And I think, to practice good medicine, it's not about it being easy by any means. It just is rewarding, right? You put in the work and you just feel so rewarded for it. So find a place where you feel like you're going to put in a lot of work and feel great about it is all I have to say.
Well, thank you, Dr. Scott and Dr. Gaor, as we have shared, references to Candid Camera and The Water Boy. Like now those people are like, what? I got to Google that movie. I've never heard of it. Never heard of Candid Camera. We will enjoy our 80s experiences. And until Chicago, thank you guys so much for joining us today.
Thank you.
Thanks, Marielle.
Appreciate it.
Next week, look forward to hearing from Dr. Michael Lovelace of Derby City DPC in Louisville, Kentucky. If you've enjoyed the podcast and you haven't yet done so, subscribe today and share the episode with a physician you may know who needs to hear about DPC. Leave a 5-star review on Apple Podcasts and on Spotify now as well, as it helps others to find all these DPC stories. Lastly, be sure to follow us on social media. If you're wanting to continue learning more about DPC in the meantime, check out dpcnews.com. Until next week, this is Marielle Concepcion.